Thanks, Dr. Eckstein, for that introduction. Welcome everyone here and on Zoom. A couple of weeks ago when Amanda spoke about the influence of COVID in our training, I kind of thought about how that influenced me to really take a look at why we do the things the way we do. And I've always been a little interested in epidemiology, but I wanted to talk about that today. This is mostly an epidemiology lecture, but we'll tie it into neurology as well. So we're going to be talking about randomized trials and show some examples of that. Disclosures, I unfortunately don't have any. If anyone has some tips about getting sponsored by pharmaceutical companies, just kidding. And I'm not an epidemiologist, just kind of read and listen to things on my own about this topic. So today wanted to go over different observational studies, a little bit of the history of randomized trials when they started. They're actually very young, in the history of biomedicine, and talk about how they benefit us in epidemiology and how they're different from some other studies. And then talk about effect sizes, the number needed to treat, and go over some landmarks, some lesser known studies in different subspecialties in our field, and then finish with a little bit of ethics and counseling of patients regarding known and unknown harms and benefits of different therapies or interventions.
Just click on this.
All right. So in the world we live in, science is mostly done, and especially in history, done by observation, right? Galileo and Copernicus studied the stars and were able to surmise that the Earth revolved around the sun. And we still do science and live day-to-day life in many ways like this. Part of that, I think, is evolutionary. Growing up, or in the history of the world, in the history of man, people who were able to see, oh, if you touch a fire, you get burned, and that's bad. So you see an instant cause and effect. If you fight with a tiger, your friend is maimed and injured, and you can see the cause and effect in a 1-to-1 ratio. It's very easy. And that's kind of how we evolved to survive. But science today in biomedicine is quite a bit different than that, because it's not so easy to know, if you take this pill every day, are you going to see an effect in 1 year, 2 years, 5 years? And how do you study that? We're also, when you just observe the world and ask questions, very prone to bias, especially when you look retrospectively. We're going to talk a little bit about different biases today, but there's recall bias, something called immortal time bias, selection bias, Hawthorne effect, et cetera. We learned about these in medical school, but they can cloud what is actually causal in the way we do science today. Another thing we're going to talk about a little bit more is confounding, but it's essentially another problem with when we observe the world, that it's not quite the reason that we think is causing an effect. And so because of these reasons, this really smart guy, well, we'll talk about him in a second, came up with is randomized trials. And so another thing that I wanted to touch on before we get into some more epidemiology is this concept of bioplausibility. In medicine, we are taught biology, physiology, and a lot of times we think that because we understand a mechanism at a cellular level, that we can have an effect, or that if we change that one mechanism, that we can change the organism or the patient in our case. However, human physiology is very complex, and it's not quite so simple. We don't exist in a test tube or a vacuum, and there's so many other influences on human behavior and physiology that it's impossible to surmise that affecting any one pathology via a cellular mechanism or some other way is going to actually affect the individual on a notable level. This concept is referred to as reductionism, and it's kind of how we all are taught, and it's how medicine has been taught for the last 100 years since medicine as we know it has kind of been around, because you reduce, the word comes from being reducing the complexity of the physiology to the sum of the parts, and you want to affect, this one protein or this one gene, et cetera. And we also use that a lot when we talk to patients, right? We reduce the mechanism of a medicine to how it works, and then we jump to the conclusion that that will cause a certain thing. However, just because something is bioplausible doesn't mean it's clinically efficacious. So the way that you have to figure out if something is clinically efficacious is if you have a signal or a hypothesis, you have to test it in the real world. So there are some good examples of this in the history of medicine. Wanted to just mention two. One is back in the 80s, there was this thought that, so we knew that if you had more preventricular contractions, PVCs, that you were more prone to arrhythmias, and people with arrhythmias had more chance of death, right? So back in the 80s, flecainide, which is a sodium channel blocker, was used to reduce the amount of preventricular contractions. And we thought that if we reduce PVCs, then people would have less death, right? That makes sense. However, someone in the late 80s or early 90s ran this trial called the CAST trial, and they randomized people to different classes of antiarrhythmics, and they actually found that flecainide, although it did decrease preventricular contractions, actually had a higher incidence of death in that group. And so it's just an example of how just because something is plausible doesn't mean that it actually works. You have to test it in outside of the laboratory, so to speak. Another example that, yeah, yeah. Another example that is more familiar to all of us is the Sampras trial, which was in the early mid 2000s. And so at the time, people thought that, oh, well, if you have a stenosis intracranially, and just like the heart, if you open it up, people are going to have less thrombosis from that area, right? It makes bioplausible sense. It worked in the heart, and people were doing it. And then someone ran the Sampras trial, and they figured out that actually when you put stents in people's into people's brains, into their vessels, they have more strokes. And so that's why we don't do that, right? Because that trial was negative and showed harm. So sometimes you actually do worse than what you thought. Had to throw a picture of this guy in because he also had a bow tie on. But this is Dr. Bradford Hill from the United Kingdom. So right after World War II, he was a physician, and he came up with this great idea. So a lot of people post World War II were suffering from tuberculosis, and the standard of care at the time was really just bed rest, don't do a lot. They had a lot of pulmonary complications from this mycobacterium. And so he said, well, let's see if what we're doing, if we can give this new antibiotic, streptomycin, and if that actually is different than what we're doing. So he came up with the first, at least historically, randomized controlled trial, which he put people into he and his team put people into groups of the standard of care, which at the time was bed rest, versus streptomycin plus bed rest. And they found that there was a benefit, and they could quantify it. And at the time, 1948. I don't know when it was published. It may have been published in 48. And this was at the time a very novel idea. It was double blind. And the beauty of doing things this way is that you balance the known and unknown confounders in each group, which we're going to talk about. All right. So a little bit about biases. A bias is a factor that influences a result but isn't causal. We learn a lot about these in medical school, but there are so many: selection bias, recall bias. We're going to talk a little bit about mortal time bias, survivorship bias, but it essentially influences your result and can cause you to have the wrong conclusion because it influences what's actually the cause of the subject that you're interested in. And the beauty of randomization is that it eliminates as best you can. It minimizes these biases because you balance the different patients or subjects into different groups. And if you do that randomly in a certain population, then those different confounders and biases will be reduced, and the confounders will be balanced. There are really three main advantages to randomization, and we're going to talk about all three of them. One is reducing confounding or balancing confounding. One is preventing selection bias and immortal time bias, which we're going to talk about. And the other one is interesting that I've learned more about recently, and that's reducing discrepancies in subgroup analyses or between different groups, and essentially testing one hypothesis. And that's very, very hard to do in retrospective studies. So it went backwards. Okay, so this one I didn't spend as much time on. I think a lot of us know what confounding is. So the classic example in medical school is you have all these people that had lung cancer and you said, what do they have all have in common? Well, when you did questionnaires or surveys, they all drank coffee. And so therefore coffee must cause their lung cancer. But then they went back and they found that, oh, actually people that drink coffee, they actually smoke a lot, or at least did back in the day. And so it's actually the smoking that's causal. So you can see that they thought that it was the coffee, but it's actually this associated behavior that's not the coffee, but the smoking that causes the lung cancer. So in retrospective analyses, you can control for what you know, right? You can control for gender, you can control for vital signs, you can control for geographic locations. Sometimes you can control for exposures, control for the medicines they're on. But the problem with retrospective analyses or other non-randomized studies is that you can't control for what you don't know about, which is many things, it turns out, that may be contributing to the result you're interested in. So the history of the patient, what socioeconomic factors influence them, what diet they have in high school, like me, where they just ate pizza and Hot Pockets. Those things are not accounted for in retrospective studies, and they could have an influence. Genetics is another one. But when you randomize people, you balance those, right? They're not eliminated, but you assume if you do have a large enough study and randomize well, that those different factors are going to be balanced and therefore will not influence your result. All right, so that's confounding. The other important aspect of randomization is that you eliminate something called immortal time bias, which I'm going to spend a little more time on. It's kind of confusing, I think, hard for me to understand. But immortal time is when a participant in a study cannot experience an outcome during some period of follow-up time for some reason, usually because of inability to experience it because their health is so bad. So let me start off with an example because I think it makes more sense that way. Not too long ago, there were several observational studies reported that corticosteroids following hospitalization, if they were prescribed, reduced rehospitalization and deaths. This is a very classic example for this type of bias, but these people had COPD, they left the hospital, they got corticosteroids, and they looked back and they said, wow, if you get corticosteroids, you're less likely to be readmitted and less likely to die from COPD. However, it was actually immortal time bias was the reason that they saw that effect, because the people who were too sick to leave the hospital never got corticosteroids. So the only people that left the hospital were already well enough to get better. So they were probably going to get better anyway. And when they did a prospective study where they randomized people, they didn't show any decrease in readmissions or mortality. And so this graph kind of shows that a little bit, but it happens a lot with prescription medicines. There's another example of metformin after a heart attack, that this time that one group cannot experience because they pass away before they're able to have this event. But when you do prospective randomized trials, you set everyone to 0, which is actually very advantageous. You can't go back and there's a time that's not accounted for in these studies, but with randomization, it's a huge advantage. Okay. The third thing that randomization gives an advantage to understand the world is that prospective randomized trials force you to test a pre-specified hypothesis. And why is this good? So it gives you an idea of how many participants you need. We call that powering the study. You have to power the study to predict a certain effect size. And so that's really helpful. And then you can't change your mind in the middle. There's actually a really interesting example that there was someone who, this was, I think maybe about 10 years ago, maybe 15, but they wanted to know if there was racism in the way referees in soccer distributed yellow and red cards. And so they had all this data, right? They have all the data of who got yellow cards and red cards, and they sent it out to all these different labs. And they said, okay, figure out if the refs are racist, or if they prefer giving these cards to certain races over the other. And they send it out to all these different labs, and depending on how each lab slice the data, you can get whatever result you want. And so it's hard to know when you look back what variables are important to include and which aren't, and who's doing the study. But when you do prospective randomized trials, it forces you to pick your hypothesis first, and then it's harder to influence the data. The other thing I'll say here. Yeah. So another thing I'll say here that's somewhat related is to beware of subgroup analysis. It's like a warning, beware. But anytime you analyze a subgroup, remember that you're breaking randomization, and you could introduce bias into your result. And so, there are all these studies that I'm sure we've read where they say, well, the trial was negative. Our hypothesis was negative. However, we looked at this one group, introduced bias, and then we found a result, right? So the solution to that is, see, if you really want to prove an effect, then you randomize those people to different therapies and see if that subgroup actually has an effect from the therapy or intervention you're interested in. Yeah. Okay. This was a really interesting, I'm gonna do it on time. Okay, I'm doing fine. This was a really interesting survey. And yes, I didn't let the irony miss me that I'm including a survey on my PowerPoint of randomized trials, but this was an interesting survey where this was in 2021, so pretty recently. This group did a survey of primary care physicians and APPs, I believe, so just primary care, but they asked them to estimate how likely their patients were to experience an outcome. And they did many different outcomes. I just included two here. How likely they were to experience an outcome. For example, in this case, it was how likely do you think your patient is to have a stroke if they have AFib? Okay, and they forced them to put a percentage down in the next year. How likely do you think they are? And the gray shaded area that looks like a mountain range is the range of responses. And then this dotted line is the average. Okay. So they said, okay, on average, the respondents said that there's about a 7 or 8% chance that your patient's going to have a stroke in a year. And then this yellow bar here is the actual chance based on the studies that they're actually going to have the results. So in other words, we tend to overestimate the chance of a bad outcome compared to the actual data. And then this is the one that's more interesting, I think, though. They then asked those same people to say, okay, how likely is your therapy that you have for this patient going to provide a benefit for them, right? And so the gray, again, is the range of responses, and then this blue shaded area is the average of those responses. So most people said about 40 to 50%, at least on average. So, however, the chance of warfarin preventing a stroke is closer to about 2 to 3%. So we tend, I think this is true based on my anecdotal experience, we tend to overestimate how much effect we're having. And I think it's important to remember the actual effect of our therapies, because it helps counseling patients and knowing what to do with patients as they come your way. So we're going to talk about in the second half about effect sizes, and then give some examples in different subspecialties of neurology. First, a slide on number needed to treat. So this is a really practical, useful way to say, how many people do you have to give a therapy to before one of them has a benefit? Because nothing is, besides a parachute, which we talked about, nothing is 100% effective. So remember that therapy reduces risk of an outcome by a certain percentage. And when you randomize people and eliminate all of the confounding and biasing that you can, you get as close as you can to the actual percent, right? It's never 100% accurate, but it's as close as we think we can get. I'll add with a caveat of modest or mild effect sizes, which is most of biomedicine. So then you take that absolute risk reduction and you compare it to this, or you compare it to the standard of care, which we're going to show examples of. And that difference is your absolute risk reduction, and you divide that into 100. So an example that most of us are probably familiar with is TPA. We always quote 30, it's about 35% chance of improvement in your modified Rankin score over the course of 90-day follow-up. So we tell people with this medicine, you have about a 30% chance of getting better. You really want to compare that to the standard of care, or at least in the original trials, not doing anything, just doing aspirin. And then about 25% of those people get better. So 25 versus 35, 10%. Number needed to treat is about 10 over the course of 3 months to have an improvement. So you just take that difference, you divide it into 100. That mathematically looks like this, although I think it's just easier to kind of conceptually think about it. Okay, and don't forget that what variable the number needed to treat is actually treating. Sometimes it's a surrogate endpoint that may not be clinically meaningful, and we'll give examples of that too. Okay, we talked about the TPA a little bit. Okay. So let's start with stroke. So it has a ton of data, always fun to look at. Back in the late 80s, there was this trial, which I had not heard of actually, but got to read about, called the SPAF trial. And this was a comparison. This is actually the one, because in the 80s, they didn't have color. So this is the black and white one over here. This shows the difference in warfarin versus placebo for patients with atrial fibrillation. And they went out to 600 days, but they reported really around a year. So right here, about 365, you can see that the difference between warfarin, I wrote over here. So on warfarin, 2.3% chance of stroke with AFib in a year on average versus 7.5% on a placebo therapy. So difference about 5%. 5 into 100 is 20. So number needed to treat is about 20 on with someone with AFib who doesn't have, who's not on therapy. So versus therapy with warfarin. And then more recently, about 10 years ago, there was this another trial, which is why we use these newer anticoagulants now, that actually compared warfarin to apixaban, and showed that there's still also a small benefit if you have enough patients to power the study, which they did. Where'd my pointer go? Apixaban versus warfarin. So I really like this study because they compared apixaban to the standard of care, which is warfarin at the time. It would have been a lot easier to compare apixaban to nothing. And sometimes studies do that. They compare that to not to the standard of care. And you got to ask yourself, is this really better than what we're already doing? Or is it just better than nothing? Anyway, so they did show a difference here. The difference is about 0.4% of apixaban versus warfarin. Now there are other benefits to this, like decreased bleeding, which was more obvious. We're not going to get into today. But number needed to treat of someone who is on warfarin versus apixaban is about 250, so 0.4 into 100. So that was really, really interesting. This was a tough one to do, epilepsy, because I really wanted to find some trials, and I kept seeing that they existed, but I couldn't actually ever find them, of the ones in the 70s. At least I read that they existed, of valproic acid versus placebo, but I could never find those. And I went, to so many journals, and I could never find it. I did find this one interesting paper that was phenobarb versus no treatment, which again, and this was in 1941. So it was like a scanned copy, and they didn't have any fancy Kaplan-Meier curves back then. They just had this chart. So I gleaned from here, but essentially they had this group of people with pretty bad epilepsy. And it was kind of funny reading this because it sounds like they just put them online and they said, okay, you get phenobarb, you get nothing, you get phenobarb, you get nothing. So maybe not quite random. But they did find that people on phenobarb versus no treatment had 25% by the end of the year after 1 year follow-up had zero seizures, zero generalized seizures. So at least to treat generalized seizures, actually reduced it to zero, which is impressive. The number needed to treat was about 4. They also had less seizures per month, but the way they quantified it was really hard to gauge actually how much improvement there was. This was a more recent study with eslicarbazepine as add-on therapy in focal epilepsy. I actually was surprised how well it did, but in their cohort, they had about 150 out of 1,000 improvement, 203 to 347 at 3-month follow-up, saying that it was a greater than 50% reduction in seizures. So that difference, 150, 15% essentially difference. So number needed to treat was 7. So a more recent example of add-on therapy and epilepsy. We're not going to talk too much today about equipoise, but my guess is that there just aren't many of these trials in epilepsy because there isn't equipoise, that these medicines actually stop seizures. So they were pretty hard to find, but this one from the 40s was, I thought, pretty interesting. Okay. Here's one from neuromuscular, and something we do in the hospital all the time. So this was plasma exchange for acute Guillain-Barré. If you're interested, Cochrane has some really nice forest plots for plasma exchange for acute Guillain-Barré. Duke didn't have access to all of the, I looked really hard and didn't want to pay $50, sorry, to get access to the actual graphs, but I found the raw numbers. And essentially in this one study, this was from the late 80s. They showed that those people who required mechanical ventilation were much less if they got plasma exchange versus just supportive care. So this was 12 out of 109 got required mechanical ventilation with acute Guillain-Barré, and then 38 out of 111 needed mechanical ventilation if they just got supportive care. And so the difference in those is 11% versus 34%. Number needed to treat of about 4 again. So 25% absolute risk reduction. And it's just important to remember, I think, in all of these, that just because you treat someone, you're still going to have people that it doesn't work for, right? So 11% of people still required mechanical ventilation, even though they got the best treatment, or one of the best treatments that we know. But it's still better than doing nothing or supportive care. So still very good. And I think another important thing here is, and there were other studies that were really good that showed time to walking and 3-month follow-up, things like that. Yeah, I think I said this before, but I'll say it again. It's important to know if the patient that's in front of you actually cares about the outcome, right? So like most people care if they have to get intubated or not, but there are other things that studies show that, it reduces your blood pressure by 5 points. Maybe the patient doesn't care about that. Is that actually clinically meaningful? And that depends on where you're treating and the patient in front of you. Okay, this is the last one as far as examples from subspecialties of neurology. So thanks, Dr. Shaw, for sending me this. This was a really great paper from 2011 on natalizumab and its role in multiple sclerosis. So really great paper. What I loved about this one was they actually had an saline placebo. So when you do a trial, you want to get as close as you can to the therapy without actually doing the therapy. So you eliminate as much as you can placebo effect, which we know is real. So if it's surgery, you want to do a sham surgery if you can, and that's going to give you the closest effect of your actual intervention, the closest to the truth. So they did a really great job in this paper. in the study where they compared natalizumab to saline infusion. Is it covered up there? There we go. Okay. And they used another thing that I liked about this paper is they used this expanded disability status scale, which has its problems, but it is a clinical outcome, which is nice. So you can show that people actually have an improvement in their quality of life, not just do you have less plaques in your brain? You know, what does that mean to a person? But they actually have an improvement in their ability mostly to walk. This is mostly a walking scale. And so they followed them for a while, but at 24 months, so 2 weeks, 112 or something right here. They showed that 17% of the people in the treatment groups, that's here natalizumab, had progression of disability, and that was defined as 1 point on this scale for longer than 12 weeks. Versus 29% of people on placebo. So I think we can learn a couple things from this. One, it's that 70% of people didn't get any worse. But then in the natalizumab group, 83% of people didn't get worse. So that's another way to look at it. But this difference is 12%. And number needed to treat is about 8, which is still pretty good. But sometimes we forget that. And I was talking to Dr. X about this yesterday. We expect everyone to respond, but really you got to treat 8 people for 2 years to have one of them not progress at least 1 point on this disability scale. And that's one of the best drugs we have, which is still very good. In biomedicine, this is a very low number, so it's still very good. Okay, am I doing on time? All right, I got a couple minutes left. So just want to touch on a couple points about ethics. I think it's important when we counsel patients, maybe not necessarily to share all of the numbers because patients don't necessarily like that. If they're me, they probably do, but most people don't. But at least to understand the effect of your therapy so you can know what to expect and also be able to counsel the patient on next steps or how their disease is going to progress despite them being on the best therapy that we have. We are very risk averse in our profession because we have so much, we see so many sick people. And so I think that's one reason we assume that everyone's just going to do worse or have a stroke or have tons of disability from their neurologic diseases. But that's not necessarily true. And we should base our decisions off the best available unbiased data that we have. Can a patient consent to therapy without knowing empirical benefit of a therapy? That's more of a rhetorical question. But I think it's important to think about, and we do it a lot with TPA. We say you have this percent chance of getting better, and you have a 5%, 6% chance of bleeding, and you have a 1% chance of intracranial bleeding. And maybe in that situation, it's more appropriate to share numbers depending on the patient. But we should understand the risk of harm because nothing is benign in what we do in biomedicine, just like the Sampras trial where they thought, oh, we're actually doing good, but they ended up doing harm. Should we even recommend therapies that don't have randomized data? I think it's tough. I think you just have to be careful that you're counseling people appropriately so that you don't inflate the chance, because most things in biomedicine don't work. Most studies don't go to phase 3 trials. And if you have a therapy that's unproven to work in a randomized trial, it's unlikely that it's actually going to affect them. And that may be what they want, but you should talk to them about that. This philosophy, you weren't going to get out of a talk with me without having some Latin in here. This philosophy is borrowed from law, but I really liked it. It's semper necessitas probandi incumbit ike agit. So the more modern translation would just be the necessity of proof lies with him who makes the claims. And so we do this a lot in medicine. We actually adopt therapies before randomized trials show benefit because we think that it's definitely going to work. But really the proof of recommending something should lie with those who prove that it works. So you have to prove something works before you use it, in other words, and recommend it, I think. And so that's kind of related to, in a sense, proving guilty. but it's a philosophy and law that I liked, and I think we can apply to medicine. As far as limitations, randomized controlled trials, again, do not necessarily tell you the truth. They have limitations and problems. There's always an intrinsic error bias that just because you have a % chance of something working, you still could be wrong. Publishing bias, most studies that are published are always positive, so you're not seeing all the negative studies. And if you took all of those, then your forest plots on your meta-analyses, which we didn't talk about today, would look a lot different. And it's difficult to do randomized trials for rare diseases. They're not always practical, especially in our field. I think it's great. Recently, there have been more trials with multi-center cohorts and that can recruit patients with rare diseases, so we can figure out what is the truth, what is the effect of an intervention. But that's also expensive. Who pays for that? Is it the NIH? Is it donors? Is it the patient? It's a tough thing to do. And in those circumstances, I understand why people want to just blast unknown diseases with steroids in our case, or whatever therapy that you want to try, because, you don't have a lot of options sometimes, but as long as you communicate that with the patient, I think you have to do what you have to do. And some pitfalls, I mentioned this one earlier, comparing novel therapies to not the standard of care. So I hope there are no oncologists in here, but cancer does this a lot in cancer medicine. They compare a new, really expensive chemo drug with a placebo instead of, like comparing a CD20 blocker with rituximab, which is the cheaper CD blocker. And they do it in other countries where it's not unethical. And then they say, oh, look, our really expensive drug has a lot of benefit, but you have to make sure when you read these studies that they're comparing to what your actual practice is to know if that novel therapy is better. And also to remember that statistically significant doesn't necessarily mean clinically meaningful. Just because something has a p-value of less than 0.05 doesn't mean that the patient actually cares or that it's actually going to make their life better. And you have to think about, is this going to cost them more? Is it going to be cumbersome for them to get this IV treatment every 6 weeks if the clinical endpoint is, I don't know, something that's not meaningful to them? So just things to think about when you're recommending therapies. Okay, the only thing I'll say here, so there's some time for questions, is the Cochrane Review is a great resource. They pretty much just review randomized trials. They redo their analyses every couple years for different therapies. I was able to get some of my studies from their website, but it's really good. They do a really a good job. So if you're interested in this kind of stuff, it's a good place to start. And we didn't talk about meta-analyses today, but they put together multiple randomized trials to show an actual effect, which adds evidence to whatever therapy or intervention that you're thinking about. Okay, so just a couple of thank yous. Wanted to thank especially Dr. Eckstein for helping me get here to Duke and also to the end of PGY4. I'm grateful for him and his mentorship. I'm thankful to Duke for giving me the chance to train here, and I've learned so much and grown so much. Special thanks to a couple mentors and attendings, Dr. Shaw, Dr. Spector, Dr. Morganlander, and other mentors and attendings that maybe are in the Zoom. Very grateful for Tracy. This is us at our family this past winter. And then some of my other family here at graduation of medical school. I'm thankful for them. She's always the one that does everything behind the scenes while I'm hiding here working on Epic. And grateful also want to thank my co-residents, especially the current chiefs over here, for their support and being on this journey together. So I'll take any questions or comments this time.
That was great, Hunter. All right, let me, any questions here while we go to the internet too?
Yeah, I'd like to.
Hunter. Hello.
Yep, go right ahead, Wayne.
Can you guys hear me okay?
Great.
Okay, Hunter, great job. Thanks for citing some of the stroke trials. One of the slides, if you really want to include, maybe next time, is actually the definition of a class and the level of evidence. That's how you define to if you need to adopt in clinical practice or not. So is this, class 1 and class 2, level evidence A, B, and C. So maybe you should include one slide like this in the future.
Yeah. The talk was getting bigger and bigger, but I think Cochrane does a good job if people are interested in class of evidence. They do a good job of laying that out too.
Yeah.
So if
All right.
anyone on the internet has a question, either put their name or their question. Anyone in the room here? All right, Hunter. So you talk about the randomized study, right? Placebo-controlled. But it turns out there's a huge difference between a randomized, blinded, placebo-controlled one center study and a multi-center study. And a guy at Stanford named Ioannidis, who I'm sure you came across, makes this huge point of that.
Yeah.
So what is that, just an effect size thing, or is that bias? What is that?
I think so. Yeah, Dr. O'Brien is talking about how if you do a randomized study at one center, you may see an effect, but then you you do all the things, but then you do multiple centers and you realize that it maybe wasn't an actual effect. And yeah, I can't say anything to Ioannidis, but from what I understand, the difference is really the bias within the institution. So they may do things a certain way, give the medicine a certain way, have a certain population of patients. So you essentially introduce non-randomized patients into the study. And so you see an effect because of their population or the way that the center does things. But then when you try to generalize that to other people, it doesn't work.
So if you're interested in this, Ioannidis is an amazing guy. He's the person who realized that if you look at the effect size of all these published studies, you can predict that there should be a whole bunch on the other side of zero.
Yeah.
And he was the guy who came up with the idea that a lot of negative results are being left out just by looking at effect size.
He said something like 70% of studies are probably negative and would never go published. And so if you put those in the meta-analyses, then maybe 1 to 5% of what we do is actually effective. And he's a big critic, but he's
smart.
He is very smart.
He's at Stanford. Anyone else with a question? Because I have one more. Chris?
Yeah, I have a, yeah.
Okay, go right ahead. Put your name in so we don't ignore you in the chat. Well, you don't have to put it in now. Just keep going.
Okay, this is Don Sanders. Can I ask a question?
Yeah, go ahead.
Okay, you use the term clinically meaningful. First of all, is there a difference between clinically meaningful and clinically significant? And secondly, who's best able to determine what's clinically meaningful, the patient or the physician?
Yeah, good questions. I think that the way we use clinically meaningful and clinically significant are different because significant, I think we use more as a statistic, which could be true, but it doesn't necessarily mean that the patient cares about that outcome. So I think they are different. And I think that's the patient that should decide what's meaningful to them. I've had patients deny therapy and I respect that. And, it helps me personally know how much chance they were going to have a benefit anyway. I think you want to push, I think you should push harder. And we all do this, I think, maybe subconsciously, but you push harder when the therapy has shown a great benefit, right? Like when someone needs thrombectomy, the number needed to treat's like 2 for the right population, you push a little harder. But if someone doesn't want to take their aspirin, I don't care that much. I'm like, well, you're probably the one of 100 or not the one of 100. You're probably the 99 of 100 who's not going to prevent a stroke from taking it. So I think you want to push harder when the effect size is much greater.
Thank you.
Thanks. That was a marvelous presentation.
It was. I just one more point. What I've seen over the years, Hunter, is that randomized placebo-controlled studies exclude certain groups of people, either because they think the whole idea of a placebo is wrong, or because different groups are slightly different in terms of how they qualify. And so when they try to sign up, they're excluded. And then their whole take home is, I've been excluded, not that I was part of a trial.
Yeah, I think that is a good point. It's hard to recruit a heterogeneous population, and maybe you always have some bias, but at least when you read the studies, you can know if you understand what population they picked, you can know if your patient would have been in that population, which can be helpful to know if they should take the therapy or the intervention.
Yeah, and this is a big issue in the Alzheimer's world. And so what they've been telling us, sure, you can have your randomized study, but if someone who's from a group you want to get involved in research doesn't qualify, you should have another study ready to go that may not be as double blinded or whatever, but they don't leave with the message, I've been rejected.
Gotcha.
Yeah. All right, any other questions anywhere? Okay. All right, wonderful job. Yeah. Really good job.